Hi, this is Dr. Amr El-Husseini. I'm a professor of nephrology, bone and mineral metabolism. I'm a medical director at University of Kentucky. And today I'm going to talk to you about osteoendocrinopathies. I will be focusing on the role of bone as a major endocrine organ. I'm not going to talk about the interaction between bone and glucose metabolism. I'm not going to talk about the metabolic function of osteocalcin or incretins, or also the adipocyte as a major endocrine gland, but I will be focusing on the bone cells, the osteoblasts, the osteoclasts, and the osteocytes as a major source of several hormones. I think I need to say that I don't have anything to disclose today. I'm part of several randomized clinical trials, multi-center trials, but none of these trials are related either to the bone or to the endocrinology practice or fields. So I'm going to focus on the bone as a pivotal organ in health and disease. I'm also going to discuss with you today the metabolic bone disorders as endocrinopathies, and the bone hormones now are a major therapeutic target. So bone remodeling is happening in our whole entire life through the orchestrated action between osteoclast and osteoblast, and this process is controlled by many hormones. So bone resorption and bone formation is going on all the time, and this helps us to control our calcium homeostasis and our skeleton. So bone is not only composed of minerals, it has organic and inorganic component. As you see here, this is an osteoclast, which is a multinucleated giant cells, comes in from the monocyte macrophage, and it starts to secrete acids and erode the bone through a raffle border to increase the surface area of contact between the cells and the bone. So these cells, the osteoclasts, start to resorb and eat the cracked bone or the old bone. So to start the process of bone remodeling, so that start to recruit osteoblasts to form new, healthier bone. Osteoblast usually works together, many of them under control of many pituitary hormone, thyroid hormone, and anabolic hormones as androgen, estrogen, and other cytokines. After the osteoblast lay out collagen, which is the organic component of the bone, it changed to an inactive cells, then die by apoptosis. So it's very important to understand the basis of this, because the skeleton is changing all the time through our life. Especially this is very active in our childhood, then start to decline a little bit when we get older. So the bone is very functional, very active organ. And the density of the bone is controlled by the balance between osteoclasts and osteoblasts. So the bone resorption and the bone formation. And these cells work together. So osteoclasts anchor themselves to the surface of the bone and start to eat out the old bone, start to eat out the unhealthy bone through secretion of several acidic environment and enzymes, then start to release the calcium in the circulation, what we need for our all intercellular activities, especially cardiac myocytes and the endocrine system. Then the osteoclasts start to recruit osteoblasts to form healthier bone. The function of osteoblasts is mainly to lay out collagen, which mainly is collagen type 1, which is a protein, but tough kind of protein. then the calcium and the phosphorus and the hydroxyapatite start to precipitate in this collagen, and now this matrix or osteoid it changed to a calcified matrix, so it's becoming stronger. And now these osteoblasts get trapped inside the bone that they form, and the osteoblast, it changes its structure and function and becomes other kind of cells, what we call is osteocyte. The osteocytes has a major endocrine function, and it actually has a mechanoreceptor and a stress sensor and start to orchestrate the action between osteoclast and osteoblast. When we get older and our hormones a little bit goes down, especially in ladies after menopause, postmenopausal osteoporosis, osteoclast is functioning more than the osteoblast, and this is the time that we start to lose bone over time. So here's the osteoclast numbers, and the all osteoclastogenesis steps and the maturation and the function is higher compared to the osteoblast function. And this all happened because of the orchestrated action of the osteocyte, which it gets stimulated by increased workload or exercise or ambulation or walking, then start to secrete the right signal for bone formation. If we have reduced loading because of prolonged recumbency or inactivity, this osteocytes start to secrete a lot of osteocalcin and other sclerostin and other hormone that can impair the function of bone formation and the wing signal. So it's very important to be active all over our whole entire life. As you see, the astronauts, when they stay in the space for a long time, they can lose a lot of bone because there is no gravity, so there is no stress on their bone. So the osteocytes become lazy and start to secrete more sclerostin. While if we are active, especially if we are doing weight-bearing exercise, we start to build up bone. So osteocyte is the brain cells of the bone. It has a lot of mechanoreceptor, stress sensors, and it has a major endocrine, paracrine, and autocrine function. So osteocyte dysfunction happen in many, many diseases, especially with, when we are talking about endocrinopathies, it happens with patients with hypothyroidism, patients with hypopituitarism, panpituitarism, and also patients with type 2 diabetes. Also, osteocyte dysfunction happen in patients with age, patients with postmenopausal osteoporosis, patients with chronic kidney disease, liver disease, and heart disease. So osteocyte dysfunction is a major endocrine problem and endocrinopathy. Osteocytes secretes FGF23, sclerostin, activin, rank L, and prostaglandin, and others, including also the OPG, the osteoprotein, and other hormone. Let's talk about the FGF. FGF23 is a major phosphatoric hormone that comes out mainly from the osteocytes, and it can, when we have very high level of FGF23, it can increase the left ventricular hypertrophy and left ventricular failure. It can induce more renal fibrosis. It increases the tumor necrosis factor alpha. It increases the CRP and the interleukin 6, and also it deactivate or downregulate the 1-hydroxylase enzyme. So the active form of vitamin B will be down. So it's very important. FGF23 goes up in many diseases, especially in patients with chronic kidney disease, and also in patients who are not active and in diabetic patients. So one of the other major endocrine function of the osteocyte is the sclerostin synthesis and secretion. So sclerostin is a signal molecule involved in regulation of bone modeling and remodeling. And it's synthesized by the osteocyte, and it actually inhibits bone formation. So when our osteocytes get very lazy, the sclerostin goes very high, the levels, and there is upregulation of sclerostin that goes to the osteoblast surface, and it binds to a receptor called lipoprotein receptors. There is several lipoprotein receptor. Then it starts to inhibit the Wnt signal. Wnt signal is very important for bone formation. So when sclerostin goes up in type 2 diabetics or patient with CKD or patient with prolonged bedridden, it inhibits the bone formation through inhibition of the Wnt signal and osteoblastic activity. So it's very important that this peptide that usually get binds to the LRB 4, 5, and 6 inhibit the bone formation. And now we have a monoclonal antibody that can inhibit sclerostin and improve bone formation through a smart pathway. Instead of inhibiting the whole cells, it can work on the osteocyte function rather than the osteocyte structure. So we talked about FGF23 and sclerostin. Let's talk about another molecule that comes out from the osteocytes, which is Activein E. Activein E is widely expressed in the osteocytes, and it increases in patients with CKD and also in diabetic patients and patients with postmenopausal osteoporosis. Inhibition of Activein E usually is very good for to suppress the bone resorption. We published several articles on Activein E in patients with CKD, and as you see here, Activein E levels goes very high in the beginning of declining of kidney function, and there is very good correlation between bone resorption parameters and the Activein E. Another molecule that comes out from the osteocyte is the rank L and also osteoblast. So rank ligand, which is nuclear factor kappa B, comes out from the osteoblast under several hormonal control, especially with the PTH, and it migrates to the surface of the osteoclast where it binds to the rank, which is a receptor on the surface of the osteoclast, and trigger activation of signal pathway that start to increase all steps of osteoclastogenesis. So increase maturation, survival, function, fusion of the osteoclast. So the osteoclast now is very hungry and it's very biologically active and start to eat more bone. So it can erode the bone and resorb the bone just in a couple days. Another hormone that comes out from the osteoblast is the OPG or osteoprotein, which inhibit and antagonize the action of rank L to the rank receptor on the osteoclast. So it inhibits the osteoporosis and counteract the action of the rank L. So patient with hyperparathyroidism, either primary, secondary, or tertiary, the PTH stimulate the action and the secretion of the rank L that stimulate the osteoclast function and the structure. So the patient start to resorb more bone. Again, now we have also medications, monoclonal therapies that can inhibit the rank L and suppress the bone resorption. So postmenopausal osteoporosis is a major issue with the rank L and the balance between rank L and the OPG or osteoprotector. Now, I'm going to talk just briefly on the current and potential therapeutic bone modalities, because now we are having more precise medicine and we can choose a smarter ways to control our bone health than just to work on the whole entire cell. We can target a molecule that can modulate the function of the bone cells. So in general, we have two kinds of bone-specific therapies. One is the anti-resorptive therapies, and one is the bone builders or osteo builders. Anti-resorptive therapy, we know about the bisphosphonates, but now we have also rank L inhibitors. Then bone builders, we have anti-sclerostin antibodies, we have teriparatide and abaloparatide. So we have different options that we can treat our bone. And as you know, that the most widely used anti-osteoporotic agent was bisphosphonates for several decades. The problem with bisphosphonates, it preferentially accumulates in trabecular bone and stays in the trabecular bone for a long time. It kills the osteoclast. So now we have a smarter medicine like Borolea, which is Adenosumab, which is a monoclonal antibody again that binds to the rank ligand and inhibits the fusion between the rank ligand and the receptor on the osteoclast. So it inhibits the osteoclast function, and it's a temporary, so you give one injection every 6 months according to the need, so it doesn't stay in the bone for very long time as the bisphosphonates, and it has been proven to increase the hip and the vertebral bone density. Another anti-resorptive agent or another bone builder agent is sclerostin. Patients with inactivating mutation of SOST, which is a gene that controls sclerostin, have resistance to fracture. In several trials in postmenopausal women, the Borosumab, which is a human monoclonal antibody, decreases the risk of fracture compared to placebo. However, it has not been compared head-to-head to bisphosphonates. Another therapy is the anti-FGF23 antibody, the Borosumab, because we know that FGF23 is a phosphaturic hormone. So if we have upregulation of FGF23 levels, the patient will suffer from hypophosphatemic rickets. So Borosumab, which is a monoclonal antibody against FGF23, it inhibited the renal leak of phosphate, especially was initially approved in patients with X-linked hypophosphatemic rickets, and now also several studies has proved and the FDA approved the use of Borosumab in adults. It decreases the risk of fracture, it increases the or improve the severity score for the fracture and the Ritek severity scores, and also the need for the phosphate replacement and the calcium replacement went down. As you see here, Borosumab improved the serum phosphorus level in patients with hypophosphatemic rickets. So this was also persistence over time. So it increased the standing Z-scores, reduced the pain, improved the physical ability, and it was very tolerable, so safe and effective in patients with X-linked hypophosphatemia and in patients with severe hypophosphatemia with upregulation of the FGF23. So there is other several studies that also has been published in the last 2-3 years in adults with using anti-FGF23 antibody in X-linked hypophosphatemia for 6 months or for a year. Most of them were phase 3 trial and proved efficacy. So now, how we control our bone health through medication, we have 2 ways. Either we have anti-resorptive therapy. The problem with anti-resorptive therapy, it doesn't really help to build up bone, but it just helps to decrease the loss of bone or prevent bone loss. But this doesn't solve the whole thing because we need also bone formation. So now we have an osteoanabolic like the anti-sclerostin antibody, but also we have teriparatide and abaloparatide. The good aspects of these osteobuilders is it increases the bone formation. So it increases the bone volume and bone density and decrease the fracture risk, especially in patients with post-menopausal osteoporosis and the diabetic patients with osteoporosis and the CKD patient. It's a sub-Q injection. So the teriparatide, the problem with teriparatide is it's a daily injection. It's a little bit expensive and you cannot give it for more than 2 years in America and 3 years in Europe because it might increase the risk of osteogenic sarcoma. And all of these reports were just an animal reports, wasn't really proved in human. It improved osteoporosis and bone loss, especially in post-menopausal osteoporosis. And the recommended dose is 80 microgram sub-Q once daily. And this patient can be on it for a year or maximum for 2 years. It can decrease the level of calcium because it improves bone formation. So probably we give with both abaloparatide and teriparatide, we give calcium and some vitamin D to help also with the bone formation. Teriparatide is a BTH-RB, so teriparatide is BTH, abaloparatide is BTH-RB, and both has been proven to improve post-menopausal osteoporosis and to decrease the risk of fracture. So take-home message, bone is now a well-described major endocrine organ, and there is a lot of discoveries and novel treatments that control the bone loss and the osteoporosis just by using more specific monoclonal antibody to control the function and the biological activity of the bone rather than to kill the cells. So hopefully in the near future, we'll have more and more of this, smarter medicine and precise medicine that can help our patient, and this therapeutic intervention probably will decrease the risk of fracture, especially for post-menopausal osteoporotic women and the patient with type 2 diabetes with osteoporosis. And staying tuned because the FDA is going to approve more and more of these monoclonal antibodies in the future. Please feel free to contact me, email me if you have any questions or concerns. And my email address is amr.elhusseini.muhammad@uky.edu.